Steve. Okay, thanks very much, Duncan. Well, in distinction to happy people in a happy clinic with chronic prostatitis, I don't think anybody who sees a patient with chronic testicular pain is happy in any way, shape or form. In fact, there's so much interest in this topic. This subject has not raised its head at BAUS since 1987. And I thought it was probably appropriate that over the last 28 years, what have I actually learnt about this condition? Well, I'm sure that we've all been used to seeing this sort of patient, 32-year-old, physically active male. He's been referred for a second opinion, third, fourth, fifth opinion. He's got isolated right testicular pain. He's got no past history, no prior vasectomy, and the pain radiates to the upper part of his thigh. It always seems to radiate to the upper part of the thigh, and it's worse with sitting, prolonged sitting, particularly in a car and exercise. And he has no pain at all at rest or when he's in bed. Now, they come into the clinic, the consultant shuffling through the sets of notes, and he decides that he really is not interested. What does he do? Naturally, he shuffles that set of notes down so the trainee sees them. So the trainee, thinking, oh my God, I've been stiffed with a second opinion. What do I do? Okay, I'll go back to basics. I'll take a history, usually not particularly illuminating over and above that which you've already got. Physical examination is normal, the scrotal contents, spermatic cord and the inguinal canal. Usually end up repeating the ultrasound scan, which of course comes back normal, and may even think slightly laterally and do a CT KUB or a CTU to exclude ureteric pathology. Right, okay, so what's the problem? Is it a testicular problem somebody's missed? Is it a benign abnormality in the scrotum, which you can feel, eureka, or is it prostatitis? Yes, it could well be prostatitis. So what treatment do you give them? Well, do you put them on antibiotics? Do you give them painkillers? Well, if you do, they get an appointment, don't they? A repeat appointment, and they come back and they are no better whatsoever. So what do you do next? What do you do next? What you want to do is you want to get them out of your clinic. So if you actually look logically at that decision-making process, a missed abnormality is unlikely, seeing as they've probably been examined by a consultant neurologist before. Benign palpable abnormalities rarely cause severe pain, and impalpable abnormalities on ultrasound scan are usually totally coincidental and not the cause of the pain. Okay, so what about the prostatitis? Well, it never causes thigh pain. It's rare without perineal pain or some urinary symptoms, as we've heard, and it's usually treated unsuccessfully over a long period of time, unless you're in Kingston, Ontario. It's often referred empirically for chronic pain management. But you need to think outside the box when you see these guys. They could have a nerve entrapment or a strain. They could have a problem with their adductor muscles, a muscular tear in their groin, osteitis pubis, lumbosacral or sacroiliac pathologies, or a problem with their hip. So think, is the pain emanating from the back or is it coming from the groin? Remember your basic anatomy, and all of the groin sort of areas are innervated from L1. And if you have pain which comes up in the upper part of the thigh, it may well indicate that there is a problem with either the genitofemoral nerve, the ilio-inguinal nerve, or the ilio-hypogastric nerve. So let's go back to the patient now. We've got those relevant bits of history. So if you've got somebody, you really need to focus on, have they got high lumbar back pain or paresthesia or anesthesia in the L1 territory? Have they got thigh as well as scrotal or testicular pain? And is their pain better at rest? Because if you've got an answer yes to any of those, then it's indicative of some nerve irritation or muscular tear, and it's not a primary scrotal or testicular problem. What do you need to do? You need to examine the back properly. And an MR may be helpful, if only to exclude a disc prolapse as the cause of the patient's pain. You need to examine the groin properly, not just running your hand over the inguinal canal. You need to invaginate the scrotum and see whether you can get the tip of your finger into the superficial inguinal ring, and indeed if there is a cough impulse there. You need to examine the hip and make sure that it is fully mobile. And imaging again may be helpful here because it may help see undisplaced stress fractures, and it may also, if you do a strain MR, you may be able to see some weakness bulging out through the superficial inguinal ring. Now, you can do that with ultrasound, and indeed many general surgeons who have an interest in so-called sportsman's hernias or Gilmore's groin, to give it a historical perspective, will just do an ultrasound, but you may miss tendon injuries and osteitis pubis. And that's what osteitis pubis looks like on an MR. It looks red hot, and it's very, very common in elite athletes. Now, sportsman's hernia is due to a problem either with a conjoined tendon tear, a tear in the transversus abdominis, or irritation of all of those nerves that are in and around the groin area. So what can you do? You can exclude tenderness over the adductor tendon. You can exclude tenderness over the symphysis pubis, and you can exclude limitation in your hip movement. And if you find a widened superficial ring and a cough impulse with invagination, and coughing and palpation in with your finger in the superficial inguinal ring replicates the pain, then you've got a sportsman's hernia. If you have imaged them and you have found, or if you found tenderness and you've imaged them and found osteitis pubis, then local steroid injections can be helpful. So, what else can you do for the sportsman's hernia? Do you manage it by rest or core stability training? Does it always necessitate surgical intervention? Well, back and core stability exercising, which can often be started by an appropriately trained physiotherapist, will be effective on patients who have moderate tenderness on palpation in their groin. And it's certainly been shown that rest does not particularly work, and that active training programs give far, far, far better results, but they last 4 to 6 weeks. If you have severe tenderness on palpation of the superficial inguinal ring or a failed conservative management, you need to consider surgical treatment of that sportsman's hernia, and this can be achieved by open surgery, or more commonly these days can be repaired laparoscopically. And this picture purely and simply shows how hernia repairs have moved on. And I was gobsmacked the first time that I saw this, having spent years and years and years stitching up bits of muscle whilst I was training. And what do? Well, they put a laparoscope in, they open up the peritoneum over Hasselbalch's triangle, they mobilise a few bits and pieces around the place, then they slap a piece of mesh on and then just spray it with glue. They don't use staples, they don't use stitches, they just spray it with glue and then close the peritoneum over the top. And does that work? Yeah, it does if you rehabilitate them properly. They need specialised physio input. The recuperation to get them back to elite sort of standard takes about 4 to 8 weeks, but there is a 92% success rate. And for those people who were sceptical about about sportsman's hernias, I think one of the things that I have truly learnt over the last 28 years is that sportsman's hernias are a true entity. They do present to urologists who, if they don't know about them, miss that diagnosis and miss the opportunity of actually treating that patient successfully. So in conclusion, once you've excluded all of your urological causes for testicular pain, you need to examine the groin, hip and back properly. Plain x-rays or an MR scan may be helpful adjuncts, and once you have done all of those things, then it's reasonable to refer that patient on for physiotherapy, to a general surgeon to repair a hernia, or to an orthopaedic surgeon if there's a hip problem, or a neurosurgeon if there is a prolapsed disc. And of course, at the end of the day, it may well be that you need some chronic pain management. Thank you.